So just for disclosure statements, so I don't receive any compensation for any of the topics of this talk. Um, so basically, for hip and knee replacements, they're two of the most common orthopedic surgeries performed, and that's because they reliably restore function and reduce pain in individuals with a common problem, which is hip and knee arthritis. They do have fairly long recoveries. Hip replacements, they'll recover a lot quicker than knee replacements, where hip replacements typically take about 3 months to recover, whereas knee replacements can take up to 9 to 12 months to fully recover. So the goal of a joint replacement essentially is to improve an individual's quality of life. And it does this by providing pain relief. It can help restore range of motion, since arthritis a lot of times causes limitations with range of motion. And then it improves an individual's ability to perform their activities of daily living, especially. So joint replacements, hip and knee replacements specifically, have been around for over 50 years. And just like anything else that's been around 50 years, they evolve with time, they improve with time. But along the way, as they're improving with time, this technology is supposedly getting better. Not everything turns out to be better with them. So there is somewhat of kind of a trial and error thing with them. But because both hip and knee replacements are a very successful procedure, any advancements, any technological advancements, should be aimed at reducing the incidence of postoperative complications, which are the biggest problems with them, even though the complication rate isn't very high. And then they should also increase the durability of the prosthesis. And that has been accomplished as time has gone on over the past 50 years. And then a big problem with, though, just like in any other industry, as technology advances, the costs of that technology kind of take over. And when a company or a hospital, whatever, has something that seems to be better, lasts longer, has fewer postoperative complications, they charge more for it. And so, as most people know, the healthcare costs, especially in this country, are just out of control right now. So really a secondary goal should be to lower healthcare costs also. So I'm going to go over these different things, which are different parts of hip and knee replacements, I think, that are being talked about a lot, and where there are some advancements, but I think also some gimmicks, and I'll go over each one of them. So one of them I talked about last year too, is a little bit more primitive last year, but it's a little bit more advanced now, is outpatient joint replacements, meaning having your hip or knee replaced and then going home the same day. And then probably the most common question I get asked, especially about hip replacements now by patients, is, do you do the anterior approach to the hip? So I'm going to go over surgical approaches to hip replacements. Another common topic now, because there's a lot of advertisements for it, is robotic total joint replacements. Then I'm going to talk about uncemented total knee replacements. And then another topic that's come up over the last several years is about whether an individual can have a metal allergy with joint replacements, and what you can do. Well, first of all, is it real? And what you do if you do have a metal allergy. So we'll start with outpatient joint replacement. So it's becoming much more commonplace, whether patients, hospitals, or surgeons like it or not. And so New England is way behind as far as other areas of the country. Other areas of the country, hip and knee replacements, as many as 50% of hip and knee replacements are being done outpatient, where patients go home the same day. Up in New England here, it's more like 20-25%. But it's coming, and I was skeptical at first, but as I've done more and more of them, and I'll go over with you with several of these slides, I think it's a very reasonable thing to do in the right setting. But we're going to have to figure this out between patients, the hospitals, insurance companies, and everything, because for reasons I'm going to go over here in a second. So traditionally, joint replacements, even when you start 30 or so years ago, patients would be admitted the day before surgery, sometimes even 2 days before surgery, and they would stay in the hospital, sometimes in traction, and then a lot of times they'd be in the hospital for a week afterwards. But as time has gone on, the hospital stay has become less and less, and patients don't get admitted to the hospital beforehand. Almost never, at least almost never they do. When I started as an attending orthopedic surgeon 21 years ago, I at that time was pretty much the standard for both hip and knee replacement patients to come in the same day of surgery, and then almost always they would stay usually 3 nights. But now, as I mentioned before, a lot of patients are going home even the same day. And if they do stay in the hospital, I would say most of them go home the next day. So the reason why this has been able to be accomplished is that we have better pain management to address patients' pain after surgery. The anesthesia has become much better with hip and knee replacements. We've used physical therapy more rapidly and effectively, both before and after surgery, to help with things. And there have been some more technological advances that have helped as well. So why should total joint replacements be done outpatient, meaning go home the same day? It's pretty much because healthcare costs have to be lowered. And so, when patients were staying in the hospital 3 nights, 25 years ago, the cost of staying in the hospital is much less too. But as time has gone on, the cost of staying in the hospital is far surpassed inflation, and it's just really too expensive to stay in the hospital. And there's some things that can happen to you if you stay in the hospital too, for patients to stay in the hospital if they don't have to. So basically, outpatient total joint replacements, for obvious reasons, cost less than inpatient joint replacements, and that's in any setting. So that's whether you do it at an ambulatory surgery center, which is a freestanding center like I operate up at Nashua, New Hampshire, or whether it's in the hospital's outpatient surgery department, essentially, which is connected to the hospital. And pretty much all parties involved, except for sometimes the patient, including the government, meaning Medicare, Medicaid, the commercial payers, the insurers, and surgeons now agree that it's the right thing to allow medically and psychosocially acceptable patients to recover at home from their joint replacement, right after surgery. And patients, if there's a positive in orthopedics to the pandemic, it has been that, at least in I would say in Massachusetts, I think other areas of the country it was earlier than the pandemic, but patients are starting to become more on board too, where they're kind of figuring out that it's not the best thing to be in the hospital. You can get COVID from other people. You're exposed to a lot of other people. We get lots of complaints from patients in the hospital that they can't sleep. They don't like the bed. They don't like the noise. They're woken up by the nurses and the doctors all the time. So if you go home, you sleep in your own bed, and nobody wakes you up or bothers you unless you want them to. And as I mentioned, there are hospital-related complications. There's a category that Medicare uses called hospital-acquired infections, and those are infections that people get from being in the hospital, being exposed to different infections, whether it's urinary tract infections or pneumonia or even COVID. So you avoid those by going home. And then more and more studies have shown that in carefully selected patients, that outpatient joint replacements outcomes have equal or even better outcomes than inpatient joint replacements. And so one of the hindrances to this was the government, so Medicare and Medicaid, up until 2017, considered both hip and knee replacements to be inpatient only surgery. So you can only get reimbursed, the hospital or the surgeon could only get reimbursed if they did the joint replacement where the patient was admitted to the hospital for however long afterwards. But then they realized, with a lot of the studies that came out, that it could be done as an outpatient. So in 2017, the Centers for Medicare and Medicaid Services removed knee replacements first from the inpatient only list, and then hip replacements they removed in 2019. In my opinion, they should have been reversed because it's actually easier to go home after a hip replacement the same day than a knee replacement. So now Medicare does not mandate patients to have to be cared for in the hospital, after the hip or knee replacement. And then because of this, over the past few years, many of the commercial insurers, the Blue Cross Blue Shield, Harvard Pilgrims, especially United Healthcare, have mandated patients younger than 65, they'll only a lot of times approve it as an outpatient joint replacement. So, and this has created a lot of problems, especially, I can tell you personally at the Baptist, we were having a lot of problems because even before the pandemic, United Healthcare was pretty much taking every patient 65 or under 65 years old and only approving as an outpatient. And we would tell the patient ahead of time, look, your insurance is only covering this for you to go home. But then all of a sudden the patient after surgery would say, look, I don't want to go home. And you always want to, you don't want patients to be mad at you, but so then a lot of times you'd keep them in the hospital and then you'd keep them one night, but then all of a sudden the next day the patient would say, look, I don't feel ready to go home. I want to stay another day. But if the hospital was only reimbursed from, that insurance company as an outpatient, they're going to lose money on it. And so that's why even New England Baptist Hospital asked us as surgeons 3 or 4 years ago to kind of identify patients that we just knew, in the office, when we would see the patient in the office for various reasons, when the insurance company would only approve as an outpatient, to tell the patient, look, you have to agree ahead of time that you're going to go home unless that same day, unless there's unless there's some kind of medical complication that has to keep you there. And then what the hospital kind of has figured out in the meantime is that you can keep, at least in the hospital setting, you can keep a person up to 23 hours out afterwards, and then still have the hospital not lose money. So those outpatient only patients that the insurance company only approves as an outpatient, you can let them stay 23 hours, but pretty much after that, you really have to tell the patients kind of whether they like or not that if that's all that they're approved for by the insurance company, that unless you have a medical issue that makes you have to be able, have to stay in the hospital, that you really need to, to go home and do the rest of the recovery at home. And then several of the Medicare Advantage plans now, these are the managed Medicare plans, are a lot of times now mandating it in Medicare patients, and we're having more and more Medicare patients in their 70s, complaining that saying I'm Medicare, I should be able to do what I want. But when United Healthcare or whatever, Blue Cross Blue Shield, which is medics, when they manage your Medicare, they can say, look, we're only going to approve this as an outpatient. So basically, why is it okay to do the joint replacement as an outpatient? So studies have shown there's really a negligible number of tests or interventions that are required the first night after surgery. So the way we do things now, you really don't need to get blood work after the night of surgery or the day after surgery. And then also between 2012 and 2015, there was a 47% increase in the number of outpatient joint replacements performed in this country. And then it's expected that over the next 10 years, there's going to be another 77% increase in them, just because, again, and I'll go over some of the studies that show that it's acceptable and okay in the right setting. So this study compared the outcomes of total hip replacements by the same surgeon, the same surgical approach, and they compared it to whether that surgeon and surgical approach was done in the hospital versus an outpatient setting. And there was no difference in the outcome or complication. The only difference was that the procedure cost $7,000 less for the procedure that was done in the outpatient setting. So obviously, if you get equal outcome and one is $7,000 less, it's better from a healthcare cost standpoint to do it as an outpatient. This is the same study by another author for knee replacements, and they showed the same surgeon, same surgical approach, whether it was done as an outpatient when the patient went home or stayed in the hospital 1 or 2 nights, that there was no difference in the outcome or complications long term. The only difference was that that it cost 30% less when it was done outpatient. So what is the American Academy of Orthopedic Surgeons, our Society of Orthopedic Surgeons, and the American Association of Hip and Knee Surgeons? So what do they say? So they kind of at first kind of defended, when it was starting to be mandated by, insurance companies, they kind of defended surgeons, and they basically said that it should be deferred to the surgeon with regard to the most appropriate surgical venue for that individual patient. So basically, they're saying that it shouldn't be the insurance company that decides; it should be the surgeon that decides. And then they also said that an outpatient joint replacement is only appropriate for carefully selected patients, and that the payment for outpatient joint replacement should be site neutral, meaning that the insurance company should pay for the procedure, meaning the implants, the surgeon's fee, the nurse's fee, the same in the outpatient and the inpatient, because what we feel is going to happen is that the first step is insurance companies making it more acceptable for it to be done in the outpatient setting. And then all of a sudden, before you know it, a couple of years from now, they're going to say, well, you know what, we're going to pay everyone less to be done in the outpatient setting then too. So, that's probably not fair. And then also, obviously, you must ensure that patient safety is optimized to maintain the trust of your patient. So you have to, you should, as a surgeon, you got to know, and you get this by experience of starting to do patients in the outpatient setting, who's appropriate for it and who's not. So who is a good candidate for an outpatient joint replacement? So you need a motivated patient that's going to do therapy on their own, in addition to the home physical therapist right afterwards. You do need a good home support. So if somebody lives by themselves at home and they don't have somebody that come and help them right afterwards, you're not a good candidate to be done outpatient. And then there has to be obviously minimal medical comorbidities. So people that have significant anxiety, they shouldn't be done in the outpatient setting, just because their anxiety is going to take over for them, the first day or two afterwards. Obese individuals, so people with a body mass index over 40, first of all, they've been shown to have a higher incidence of complications, but they have a harder time getting around. They're harder time, the therapist helping them, so they're probably better done in the inpatient setting. And then obviously individuals that have significant medical problems that really need to be monitored in the hospital. So if somebody has, a history of a heart attack in the past, if they have a history of atrial fibrillation, or if they have kidney failure, those patients really need to be monitored afterwards. And those, like if an insurance company only approves as an outpatient, and you can appeal it, and in the appeal, if you say the person has atrial fibrillation, they're on blood thinners, they'll sometimes, or I would say a lot of times, do the right thing and say, okay, then we'll do it then we'll approve it as a inpatient. So what is needed to provide a patient outcome? I just have to plug this in. Sorry. So bigger thing is we kind of have needed to become more efficient in surgery. So surgical time is a little bit less. Patients can't have really large blood loss, and this has been really improved over the last several years by using this medication. The abbreviation is TXA, or tranexamic acid. So it's, even when we do, the patients in the hospital where we do check blood counts the next day, it is extremely rare that we ever have to give somebody a blood transfusion after a hip or knee replacement, since we've been using this medication called tranexamic acid, which makes patients bleed significantly less. And you really need to optimize patients' pain management right after surgery. And then this is done by, so a lot of times when an individual has a spinal anesthesia for their joint replacement in the hospital, they'll have the procedure and then their spinal is still working 4 or 5 hours afterwards, so they still can't move their legs 4 or 5 hours later. So in the outpatient setting, they're shorter acting spinal, so that, when the patient comes out of, the operating room, 20 or 30 minutes later, the spinal anesthesia is wearing off. And then also, by doing spinal anesthesia versus general anesthesia, patients have much less nausea, which is something that, makes them obviously feel bad afterwards. And then with general anesthesia, people kind of have the sedated, kind of drunk feeling afterwards, which you don't have with spinal anesthesia. So actually, I would say 95% of hip and knee replacements now, whether it's the inpatient setting or the outpatient setting, are done with spinal anesthesia. And then the biggest thing I think, which has helped, at least the initial recovery, is that the nerve blocks that are done and the local injections that are done around the hip or knee replacement are significantly better, so that there's a lot of times not very much pain the first day of surgery. So even when the spinal wears off, there's usually not a lot of pain. Unfortunately, those nerve blocks and the local injections wear off a lot of times the next day. But then usually a lot of times it's actually easier to have your ride home or drive home the day of surgery, because it doesn't hurt as much, versus the day after surgery if you stayed in the hospital overnight when the nerve block wears off and you're having a lot of pain, especially with knee replacements, and then have to make sometimes a long drive home. And then also there needs to be a nurse or case manager assigned to every patient in the outpatient setting to make sure that there's a home therapist. So basically, when you go home from the surgical center the same day, the physical therapist works with you before you leave, and then a home therapist comes in starting the next day. They usually come in 3 times a week. And then there's also some preoperative education with physical therapy and setting up telling a patient how to set up their home and things like that prior to surgery also helps. What do I think? Again, as I mentioned before, I was skeptical at first, but I'm doing more and more. Outpatient, some is kind of being forced on me, but I also think it's acceptable in the right setting. And it's really, as I mentioned before, it's coming whether we like it or not. It does require more work for the surgeon, because you do have to kind of spend more time with the patient before surgery and right after surgery, kind of explaining things, what they need to be doing right away at home afterwards. And there's a lot more phone calls from the patients afterwards to their office, because they're obviously home the next day versus in the hospital where they could be asking the nurse, or the doctor or case manager, in the hospital. And usually patients tend to trust their surgeons to do the right thing. And I think that happens, obviously the vast majority of the time. It is a little more inconvenient for the patients, as mentioned before. But you just got to keep in mind, many of the things that patients complain about in the hospital are eliminated. The too much noise, they don't get their pain medications on time because they ring the bell for the nurse and it takes 20 minutes for the nurse to come. While at home, you have your pain medication bottle right next to you. There's no nurses or doctor that's wake you up. You don't get a bad roommate that snores. So those things are eliminated, obviously, at home. All right, so moving on to the next thing. So the surgical approaches for hip replacements, that I mentioned before, it's one of the most common things that I hear now as far as hip replacements. So traditionally, for many years, there were 2 major approaches to hip replacements that were done. There's the direct lateral approach, and then there's the posterior approach. The advantage to the direct lateral approach was that the dislocation rate afterwards was lower than with the posterior approach. But with the direct lateral approach, the strongest muscle of the hip, called the gluteus medius muscle, in order to get into the hip joint, you'd have to take 1/3 of it off, and then you repair it at the end. And then some people, they pull off the repair and have some weakness or have some permanent limping afterwards with the direct lateral approach. With the posterior approach, you don't touch those really strong muscles. You do take off what are called the short external rotator muscles, which are very small. One of those is the piriformis muscle, which people have heard about. But you go through the posterior capsule, and you do repair it at the end of the case. But the posterior capsule is the thing that helps hold the hip replacement in the most after surgery. So that's why with the posterior approach, there is always a slightly higher dislocation rate than the lateral approach. However, people have gotten away from the direct lateral approach because of the gluteus medius muscle that comes off as part of it, where some people get some permanent weakness and limping from it. So the posterior approach has still stayed around, and just because it's a fairly fast recovery and it doesn't really cause any significant muscle damage or functional damage. The only thing that's happened with time is that our incisions have gotten a lot smaller, and sometimes we try to release a less amount of those what are called short external rotator muscles. But the approach that's starting to gain popularity is this direct anterior approach, which has been significantly marketed, especially by younger surgeons that are closer to their training, that they're trying to kind of market it as an advantage over older, more experienced surgeons, that they have something new that might be better. So what are the difference between the anterior and posterior approaches? So with the anterior approach, the scar, or where you go into the hip, is in the groin. So it's kind of near your groin crease, so on the front of your hip. Whereas with the posterior approach, it starts kind of on the side of your hip and goes into the butt a little bit. So it's a different location of the incision. So with the direct anterior approach, people that try to market it claim that it's associated with less muscle damage and pain and a more rapid recovery. But this is debatable if you look at the studies. Now, the other interesting thing is people that do the anterior approach, they'll say it's a new approach. But if you look in the literature, it actually has been around for a long time. It was first started by a surgeon in Connecticut, Chris Kagi, in 1980. But nobody really didn't really become popular at that time. But then there was a trauma orthopedic surgeon out in California, Joel Mata, probably about 15 years ago. He started doing it for total hip replacements, and then it really kind of started taking off after him. So even since it's become very popular, it's been around like 15 years. So it's not, that new essentially. So with the anterior approach, as opposed to the posterior approach, it's done with the person flat on their back, but it's very hard with the anterior approach to get access to the femur part of the hip replacement. So many people, I would say most people, and actually every surgeon at the Baptist that does the anterior approach except one, you go on a traction table like you have in this picture. So your foot is in traction the entire case. And so that can actually have some advantages. There are disadvantages. It can actually, we've had people have an ankle fractures from their tibia fractures, and some people can get traction nerve injuries or skin breakdown from it also. It also requires this special table that's pictured here called a HANA table. That HANA table costs over $100,000 just for that single table. And then when anterior approaches were first done, one of the reasons why they were done back in 1980, started in 1980, but didn't really take off, is because the implants were harder to position during the anterior approach. So because of that, with these traction tables and special tables, you can get an X-ray machine in there. So a lot of people that do the anterior approach use an X-ray during the procedure to kind of make sure that the implants are going in the right position doing it. Whereas with the posterior approach, you don't really have to worry about that. Your landmarks are easier to see. The disadvantage to this X-ray is that the patient is exposed to a lot of X-ray during the surgery, which you're not exposed to during the posterior approach. And then the operating room staff has to wear these heavy lead gowns, which can be fatiguing. They can hurt your back, which you don't have to wear, obviously, if you're not using X-ray during the procedure, like with the posterior approach. Then the incision. So it's interesting. The people that market the anterior approach, they say that they market it as being minimally invasive. But if you look at the size of the incision, these are two patients here. Essentially, the size of the incision is about the same. But when the anterior approach is done, the one on the left here in the groin, because where it is in the groin, near the groin crease, the skin kind of, like as you flex your hip, kind of moves. So as the skin heals with the anterior approach, the scar usually widens like the one you see on the left. Whereas with the posterior approach, because it's in an area where the skin doesn't really tighten and loosen, it's more of a thin line when it heals. So cosmetically, the posterior approach incision, I think, looks a little bit better, afterwards. And like I said, it's about the same size, just a different location. So the other thing is there have been several studies that show that if a surgeon is interested in switching, if they've always done a posterior approach or a direct lateral approach, and they want to switch and start doing the anterior approach, there have been several studies that show that there's a really high complication rate in the first 100 or so cases that an individual does. And you have to ask yourself, is it worth subjecting those 100 patients to a significant increased risk of complications, just for you to be able to get out of your learning curve, basically? And that's debatable, and I'll go over a statement about this later on. And then when you look at the direct anterior approach versus the mini posterior approach, there's a lot of this marketing that says that there's less muscle damage, there's less post-op pain, quicker recovery, better gait mechanics, but there's scant evidence in the literature. And so basically in medicine, if you have something that's better, and you want to say it's better than another approach, it's always been that you do a study, you do a well-done study that you can publish in a peer-reviewed journal that's, reviewed by other, orthopedic surgeons or medical people, to know that it's a well-done study to show that something is better. But unfortunately, what's happened a lot of times now is that people just go in, the surgeons, hospitals, whatever, medical device manufacturers, they just make the claims. They'll just say on there that it's less muscle damage, quicker recover, whatever, without a specific study. But there are many studies now in the literature that compare the mini posterior approach to the direct anterior approach, and I'll go over those with you. So what does the literature show? So there are conflicting results. So is the direct anterior approach truly muscle sparing? So if a surgeon says that I don't cut any muscle with the direct anterior approach, I hate to say it, they're lying to you. So the ball of the hip that comes off as part of the hip replacement, whether you do it through the anterior approach, lateral approach, or the posterior approach, has some of the short external rotator muscles that are attached to them. So whether you say you cut them off or rip them off or whatever, some of them are coming off during the anterior approach. And then many people with the anterior approach, there's this thing called the rectus tendon and muscle up at the side of the hip. Because it's hard to get exposure to the femur, many surgeons end up releasing part of that rectus approach to rectus tendon, which is obviously a muscle too. But at the same time, there have been studies. So Bergen et al. In this Journal of Bone and Joint Surgery study in 2011 showed that if you measure muscle damage by blood levels after surgery, the anterior approach had some too. Obviously, as I mentioned, there is some cut too, but the posterior approach had slightly more. But again, the anterior approach has some. Now, is there a faster recovery with the direct anterior approach? So there are many studies that show that there's a sooner discharge from the hospital with the anterior approach, but these are in the past. Like I said, with my previous discussion, a lot of patients are going home the same day anyways now. Then some studies show that there's a little less pain in the immediate post-op period, the first few days after surgery with the direct anterior approach versus the posterior approach. And then some studies show a slightly quicker functional recovery at 6 weeks, but then after 6 weeks, there's no difference. But the problem with a lot of those studies that compare the two is that because, as I mentioned to you before, that the incision for the direct anterior approach is in the groin, a lot of surgeons that do the anterior approach don't do obese patients with the direct anterior approach because their pannus in the obese patients hangs down over the incision, and then you get wound healing problems. There's a higher incidence of infection with that. So we also know, as I mentioned before, with the outpatient talk that I gave, that obese patients tend to recover a little slower than non-obese patients. So a lot of these studies that were done comparing the anterior to the posterior approach, the same surgeon would obviously do the posterior approaches on his obese patients, and the anterior approaches on the easier patients to do the anterior approach on, the more motivated patients or whatever. And so a lot of those studies are biased, and so may not have this, this slightly faster recovery as they say. But this is the other main thing that you have to take in consideration, is that there are multiple studies that compare the two approaches, and there is a higher complication rate with the anterior approach versus the posterior approach. They bleed more, the surgery takes longer. Those shoulder external rotator muscles that we mentioned before, when you do a posterior approach, there's blood vessels in them. You cauterize them as you take them off. When you do the anterior approach and you take the head out, you don't see the blood vessels, so they just bleed the whole time during surgery. You're under anesthesia longer with the anterior approach because it's a longer surgery. As I mentioned before, there's higher wound healing complications because of the skin flexing, and sometimes people with the pannus hanging down over their incision with the anterior approach. And then this is a big one. So there's a nerve that comes down the front of the hip very close to the incision for the direct anterior approach. And that nerve supplies sensation to the front and side of your thigh. It's called the lateral femorocutaneous nerve. It's not a motor nerve. It doesn't innervate a muscle or anything. So when it's damaged, it doesn't cause weakness, but it causes numbness. And so there's a large percentage of patients that have the direct anterior approach. One study showed as many as 2/3 of patients that had it done end up with a numb area, which oftentimes is permanent, on the front toward the outside of their thigh. And it happens so frequently that people that do the anti-approach don't consider it a complication. And they'll say, well, look, it doesn't cause, if it doesn't cause weakness, who cares? But a lot of the patients that I will do a redo or revision on from one of the complications that happened during the direct anti-approach to the hip, they'll say to me beforehand, hey, while you're in there, can you make me be able to feel this area of my thigh again afterwards that I haven't been able to feel since the surgery? And the answer is no, because when that nerve is damaged, it's damaged for good. And then, as I mentioned before, because the person's in traction, oftentimes for the anti-approach, you can have issues associated with that. So in the earlier days of the anti-approach, the one complication that was higher with the posterior approach versus the direct anti-approach was dislocation. The dislocation rate's not very high for the posterior approach, it's 1% to 2%. But with the anti-approach, when it first came out, the incidence was less than 1%. So there was a difference. But there's a higher incidence of fracturing the femur during the direct anti-approach versus the posterior approach. And that's because the posterior capsule, which is still on during the anti-approach, which helps hold the hip in, is one of the things that prevents the femur from getting good access during the surgery to put the implant in. So what a lot of surgeons do now, in order to limit the risk of fracturing the femur, when they're struggling during the surgery, they'll reach around and cut the posterior capsule. So that allows them to have better access, during the anti-approach. But because you're operating from the front of the hip, you can't repair the posterior capsule then like you do through the posterior approach. So that's why some more recent studies, like I show here, show that the dislocation rate has become equal with the direct anterior and posterior approach. This is definitely what we're seeing at the Baptist. When we go to morbidity and mortality conference, every month, we see just as many dislocations, if not more, with the anterior approach versus the posterior approach, just because people are releasing more of the posterior capsule with it, even though we're seeing less fractures with the direct anterior approach. So what do I think? I think the biggest thing is you have to be careful about misleading marketing, especially from surgeons. The bottom line is, if you look at studies, that there might be a slightly faster recovery by a few weeks with the direct anterior approach, but there's a higher incidence of a complication. So the way I look at it is, I've chosen not to switch from a posterior approach to my mini posterior approach to the anterior approach, because I think the recovery is very fast with that. I'm happy with my complication rate. I don't want to increase it. I especially don't want to subject 100 patients to a learning curve where the complication rate is much higher. And the way I look at it is it worth having maybe a slightly faster recovery by 2 weeks to have complications, sometimes that's permanent, like a nerve palsy? The incidence of sciatic nerve palsy and femoral nerve palsy is higher with the direct anterior approach too. And me personally, I don't think so. So I'm biased, obviously, because I do the mini posterior approach, but that's why I haven't switched over to the direct anterior approach. What has the American Association of Hip and Knee Surgeons said? They have specifically stated that they recommend that a surgeon use the surgical approach that they were trained with, because there's no compelling evidence in the literature to switch to the direct anterior approach. So in other words, they're saying that the potential benefits do not outweigh the risks, especially when you switch to the anterior approach, you go through that learning curve. So the next thing I'm going to switch to is robotics. There's a lot of marketing now for hospitals with this. So with robotics, there is a robotic arm that makes the bone cuts that normally a human, essentially the surgeon, makes during the procedure, but it also helps align, the cuts that are done too. And in these cases, you have to get a CAT scan or an MRI examination before the surgery, and then the robot kind of uses that information with different landmarks with either the hip or knee replacement, essentially to make its bone cuts. The most common one, the one you'll hear about the most, that's been marketed the longest, is this one called, it's pictured here, the Makoplasty, that Stryker has bought now. That's been the only one that had been out for a long period of time, but pretty much almost every joint replacement company now has a robot that's come out. One of the problems is, again, as I mentioned before, new technologies, they tend to charge a lot of money for it initially. So each one of these robots, so the Makoplasty, when it first came out, when Stryker bought it about 4 years ago, they're charging $1 million for that robot that you see in that picture right there. It's a little cheaper now, just especially because there's competition with a lot of the other companies coming up with their own. So obviously it's very expensive. And the way I would look at it is it's highly marketed but poorly studied. So there's very few studies in the literature that address this. There's not a single study in the literature that's not biased, that's not paid for by one of the companies that make it, that show that it improves the clinical outcome, how the patient does, how the patient recovers, even though a lot of surgeons will say, oh, there's a faster recovery because a robot does it. No studies show that. It does take a longer amount of time to do it versus doing it conventionally. There are studies that show that the alignment is a little bit better. There are fewer outliers in alignment compared to when the human does it versus the robot. But this better alignment has not translated to any studies showing that there's any better clinical outcomes. So why does this new technology not get better outcomes? So everything, especially with knee replacements, is not about the alignment. So much of a knee replacement is balancing the knee, balancing the ligaments in the knee. So a lot of times when people come into a knee replacement, the arthritis has made their leg crooked, and then you have to straighten it. And even the robot straightens it just like I would straighten it doing it myself. But when you straighten it in a knee that's been crooked for a long period of time, the ligaments don't balance. So you have to do things during the operation to balance the ligaments. The robot does not do a very good job at that right now. So I think the individual surgeon, their experience does better at that. Now, the robots, that's probably the next step for the robots, is that to have them start doing that too, but it's really not there right now. In my opinion, the surgeon is the key to a well-done knee replacement from a surgical standpoint, and that's based on their experience. And then, oftentimes when I'm straightening or balancing a knee, I play around with the implant sizes, to balance the knee, whereas a robot, before you go into the surgery, already knows what size implants they're going to put in. You could pretty much open them before you even start the case. Whereas when I do a surgery, myself without the robot, I size things. Once I balance them, I figure one size might be better than the other one, and so I make adjustments basically based on that, whereas the robot does not. So do I think. When we first bought our first robot at the Baptist 2 years ago, I was kind of excited about it. I thought that it made sense. But the reason why I don't use it routinely right now is that I pride myself on using a small incision. And in order to use the robot, you have to, for me personally, I have to make an incision at least 3 inches longer than the one that I normally do to get these special pins in, and allow the robot to get a better access to the implants. And for what the robot was telling me during the surgery, for the ones that I did at the beginning, I did not feel that the making a longer incision was worth what the robot was telling me. Because there are times when I would do it that I would, especially with the ligament balancing, that I would kind of sometimes disagree based on my experience with what the robot was telling me. And even the guys that use the robot all the time at the Baptist still, periodically they'll abort during the middle of the case and say this just isn't right. But if you have a less experienced surgeon and they're just going to completely rely on the robot, you got to be a little bit careful. But if you do have a less experienced surgeon from an alignment standpoint, it might be a better thing because they don't have as much experience doing the actual, the cuts themselves. So I don't think it's at the point right now of, every surgeon should use it. I think it's actually the opposite, but I do think as time goes on, these are going to get better. And I think in the future, they're going to be used much, much more commonly. So next thing I'll move on to, so for total knee replacements, so total hip replacements are pretty much almost all uncemented, where they have an implant that the bone grows into them. So traditionally, knee replacements have always been cemented. So when a patient asks me how long their implants are going to last, I tell them hip replacements tend to last 30 to 35 years now, knee replacements last 20, 25 years. Why is that? So more knee replacements, especially the ones that have been in 20, 25 years, are cemented. Cement breaks down, quicker to loosen things. Whereas if you get an implant that grows into bone, they typically last longer. The problem is that with knee replacements, there have been multiple attempts over the past 20 years or so that hip replacements have all become uncemented to have them reliably grow into bone. It just hasn't happened, but that's changing, especially more recently. So several studies, 10 years ago with press fit on knee replacements showed that 5 to 10% of them sometimes didn't grow into bone. And then the problem is if they don't grow into bone, you end up with another revision surgery, a year or two later. So in that setting, that failure rate seemed to be too high, and that's why most people would still cement. But now with better implants and better technology, it seems like they're more reliable in the right setting. But the things you have to take into consideration is that the reason why, in general, patients are happier with hip replacements and knee replacements is that knee replacements have a different feel than a normal knee, whereas a hip replacement feels like a normal hip afterwards. Whether you cement or press fit the knee replacement makes no difference with that at all. It all has to do with the fixation of the implant, how long it might last. So the feeling doesn't make any change at all. There now are studies out for the more recent implants out to 10 years that show that the more modern press fit implants, especially when they're done in people with better bone, are equivalent. So they don't have a higher loosening rate than cemented ones at 10 years, which probably means, my bet is that those, at least in the right people that were done, probably that they'll last a little bit longer than the cemented ones. What do I think? So the problem is that there's different people with different bone quality. So the older you are and the less bone quality is, the less likely that person is to have bone that grows into their prosthesis. So what I've started doing is that when I have a younger person, especially more active, I'm concerned about loosening of the implants earlier, breaking down the cement, and especially if that individual has good bone, I press fit, I don't use cement. Whereas with older patients, the bone's not as good, they're not as active, I think you're better off going with cemented. So I kind of use a hybrid thing where I kind of mix and match my patients, whether I cement or don't cement. So this is the last thing I'll talk about. This is another thing that patients are really coming in and talking about a lot. And this is being brought on by a lot of marketing, especially from one specific joint replacement company that makes what they call hypoallergenic implants. So there's this thing, can somebody be allergic to the metal of their implant, and can this be a problem? So the reason it's becoming increasingly prominent is that there's a lot of stuff on the internet about it, and there's a lot of marketing about it. However, there's minimal ambiguous science, and it's not clear how this would be a problem, essentially. But you just got to remember that even the company that makes this hypoallergenic implant, there's still metal in it. It's just that most people, when they're allergic to metal, are allergic to nickel. And so almost all knee replacements, the metal is cobalt chromium. It's not titanium, because cobalt chromium, if you think of cobalt or chromium, or like on a car, it's very polished. So when a metal rubs against plastic, if you don't want it to wear out very quickly, you want it to be a very smooth surface, a very polished surface. So that's why cobalt chromium does better when it rubs against plastic. Now, in hip replacements, it's not an issue because you can use a ceramic ball that rubs on a plastic liner, but ceramic you can't cement in a knee replacement. You also can't press fit it in a knee replacement either. So here's the issue. So 11 to 14% of the general population is allergic to nickel. That's a lot. In cobalt chromium, there's approximately 1 to 3% Well, 1 to 3% of patients are allergic to cobalt, which is in cobalt chromium. The problem is that in cobalt chromium, 1% of cobalt and chromium is nickel. So is that enough to cause an allergic reaction in somebody that's allergic to nickel? And that's very debatable. The reason I put these other ones up there, titanium and zirconium. So the company that makes the hypoallergenic knee, Smith & Nephew, the metal in there is titanium and zirconium. You can see they also have nickel in it, but not the 1% like cobalt chromium does. It's 0.1% in titanium, and the zirconium has much less than that. So, as I mentioned before, in hip replacements is not an issue. Nobody uses cobalt chromium in hip replacements anymore. The hip replacements are all the metal is titanium that the bone goes into, and it's a ceramic head that rubs on a plastic liner, so there's no cobalt chromium. So you don't have to worry about it with hip replacements. As I mentioned before, it's different with knee replacements. But if you look at the literature is really not clear whether this is actually a problem. And it's essentially controversial. So there are some scattered case reports where a surgeon will report 3 patients that he had that had a nickel allergy that had a poor result, had a rash on their on the front of the knee, or had didn't get their motion back after knee replacement, whatever. But those studies are case reports. They don't compare them to other knee replacements where people didn't have a metal allergy. And then also several of those studies that are case reports have shown this rash that is now noted that it's when people have a knee replacement done, the incision is done down the front of the knee, and the way the skin nerves come in, you end up with a numb area to the outside of your knee, a small area, and in that area, it's common to get a rash that's related to the. It's a well-known thing that neurologists know. It's related to having numbness there. So a lot of times, those case reports that have been shown to have a rash with the metal allergy patients aren't actually a rash from the implant. It's a rash related to the to the skin. So what do you do if if a patient thinks they have a metal allergy? So the most common thing they do is they go to a dermatologist and they get this done. They get a patch test where the dermatologist puts all these different things on their back and then checks them at 1 and 3 days to see if they have a rash to them underneath it. This is usually covered by insurance. So if you want to truly know whether you have a nickel allergy or cobalt chromium allergy, you can go to a dermatologist and get a patch test, and it'll probably be covered by your insurance. However, there are no studies that have been shown that show that a person with a positive patch test, meaning nickel allergy, and if they had a nickel, like if they already had a knee replacement put in that has nickel in it, that it correlates to a bad result, basically. So also there's this large Mayo Clinic study that came out that showed that when they took all the patients that had failure of their knee replacement sooner than what they should have, and then they tested them by patch test or by this other test I'll show you about for metal allergy, there was no correlation between the patients that had a metal allergy and not, and whether they had an earlier loosening rate. There is this test that's being kind of marketed and probably does test whether an individual has more of a systemic versus just a skin reaction to nickel. This is called a lymphocytic transformation test. This is not done by very many labs. There's a special lab in Chicago called Orthoanalysis Lab, which is mentioned here. The problem with this test is it's expensive. It's about $600, and insurances usually don't cover it. But it's a better test, even though this hasn't been completely validated either. But this also measures bone cement too, because some patients are allergic to bone cement. But this measured more of a systemic reaction versus just a skin reaction. So this is what I mentioned before. There's this company, Smith & Nephew, that makes this oxinium, which is a kind of a ceramic, but also metal femur with a titanium base plate. Zimmer Biomet makes a titanium femur, but titanium you can't polish like you can cobalt chromium. So when you have titanium that rubs against plastic, we know from other studies in hip replacements when we use titanium heads on plastic that they wear out quicker. And there's a newer thing. Escalep is a company that has made a gold knee replacement, that the metal is gold, which is obviously more polished, but obviously more expensive also. So the problem with these is that why wouldn't we just use this on every single patient? So Smith and Nephew says, because there's all these, the 11 to 14% or 11 to 13% of patients with a nickel allergy, why not just use our implant for every person, because we have such negligible amounts of nickel in our thing? But it's because of this. If you look at the Australian registry, when you took that Smith and Nephew implant and compared it to cobalt chromium implants, and this is whether people have a nickel allergy or not, there were more revisions, especially earlier revisions for the Smith and Nephew one versus the cobalt chromium one. And again, that's because cobalt chromium is more polished, rubbing against the plastic, and that's the picture of the black one there is the oxinium one, and so that's why we don't use them on everyone. So what's the practical approach? I'm not sure I believe it. I think there might be some degree of it, but I don't think routine testing is indicated. It's certainly not cost effective, especially with how much those test costs I just showed you. If a patient gives me a history of metal allergy, I tell them, look, if the literature is not clear with this. However, if you really insist that you don't want an implant with nickel, cobalt, or chromium, I'm going to put this one in that I don't think does and has been shown in studies to not do as well. You just got to realize that. So what some patients will do in that situation is then they'll pay that $600 to go get that lymphocyte transformation test, hoping that it says that systemically they don't have the allergy, that it's more of a skin allergy, and then they'll just take the cobalt and chromium one. But if that one does show sensitivity, then it's hard on that person not to do one of these hypoallergenic ones. I don't bring it up. And like, I don't ask every patient, do you have a nickel allergy? Because I don't want to be doing a lot more of these, I feel somewhat inferior knee replacements, because I'm worried about having to redo more of them too. So that's, we're just wrapping up about an hour now. So sorry, I think it went a little bit late, but so those are I think the more kind of more recent things that people are talking about. Is anyone have any questions? And if anyone has any questions, you can either send it through the chat function, or the easier thing is to just unmute yourself and then just ask, and I'll answer answer the best I can.
I'll jump in with a question if you don't mind. I'm
Sure.
curious to hear some thoughts about what has changed for revision surgery. Are there new and exciting things that make that process easier?
Yeah, that's how we try. I didn't bring that up just because it's not as common, but a large percentage of my practice is revisions. I know when I was at UMass Medical Center, about 20% of my practice, 20% of the surgeries I did were revisions. It's a little less at the Baptist, just because more of us do it there. But revisions have gotten a lot easier. There were certain things, when I first went into practice, 21 years ago, there were certain things that you would encounter in revisions, both in hip and knee replacements, that just did not have a good option there, and you just had to make the best of things. But especially with knee replacements, there are these things called cones and these trabecular metal devices that you can now put in that also grow into bone. Whereas we used to, especially with revision knee replacements, have to just, when something loosened, you'd have to put a longer stem in that you would cement even farther down the tibia or the femur. And now with these implants that can partially grow into bone, even in the revision setting, it's significantly helped us. And then same thing with hip replacements, revisions. The implants have become so much improved that make the revisions easier. They're never easy. They're certainly harder than the first time cases, but there are more options for badder problems, basically. We always get this, patients will come in and say, I heard you can only have it redone once or twice, and that's definitely not true. I've had people I've had it done like 5 times or 6 times, and those are the people that you kind of run out of options. But now there's really an option for everything, I think.
Thank
Anyone
you.
else? Sure.